boundless energy. It's exhausting to see all of the things that she does and is involved in, and just the most importantly, her compassion for patients and their families. And I think that's really what drives all of us as we think about why we're here, why we're listening today, is just the recognition of how we can ensure that every child everywhere gets access to high quality care, that all of our patients and their families suffer in some way as they navigate their illness and as they navigate their treatment. And to have someone like Dr. Resham to describe how we can integrate high quality palliative care to reduce that suffering, to reduce that anxiety, and to really make sure that we are the best physicians that we possibly can, I think is just wonderful. And so I could talk about Dr. Resham all day long, but you want to listen to her and not to me. And so I'll pass it back to Dr. Mariah for the formal introduction, and that we can all listen to Dr. Resham. And just thank you all for being here today.
Thank you, Michael. Thank you very much. Dr. Shahzadi Resham, MBBS, FCPS, and MD. She is a pediatric palliative care physician, a pediatric bioethicist, pediatric hematologist and oncologist, and assistant professor at Department of Pediatrics and Child Health, Department of Oncology at Aga Khan University Hospital, Karachi-Pakistan. Dr. Resham, born and raised in Karachi-Pakistan, and underwent medical schooling at Sindh Medical College and pursued postgraduate medical education at Aga Khan University Hospital. She completed 3 PGME graduations from there, including internship, a 4-year pediatric residency, and a 3-year fellowship in pediatric hematology and oncology. Recognizing a huge void in pediatric palliative care in Pakistan, she decided to voluntarily step in to establish and develop a comprehensive pediatric palliative care program at Aga Khan University and across the region. Dr. Resham furthered her expertise by completing a global palliative care fellowship at St. Jude Children's Research Hospital, becoming a key pediatric palliative care leader and a pioneer in the country and further the East Mediterranean region. And I also mentioned you that Dr. Resham is also one of the past co-chairs of Palliative Care Working Group, and it's an honor for me to take the duty over from her, and I thank her again for all she did and ongoing support for our Palliative Care Working Group. So, Dr. Resham, the floor is yours. Thank you very much.
Thank you so much, and thank you so much, everyone, for joining in, and thank you so much, Mike and Mirai, for such a generous introduction. And I think I'm already full of listening about myself right now. How I'm going to present it for the next hour, I don't know, but I think we learned from each other, and the amazing group and the amazing team which I had spend a time at St. Jude. Amazing people, amazing compassion. I think I am trying to deliver that compassion which I have received from them to the other people in Pakistan and across the globe. So thank you so much, Team PSYOP, and thank you so much, Palliative Care Working Group. Without further ado, I'm going to share my screen. And just, Mirai, if you could let me know that this is fine for now. Is the screen visible?
Yes, yes, it is.
Okay, perfect. Thank you so much for joining in. And so without further ado, I'll start the presentation. I have no relevant conflict of interest or disclosures. So we will be talking about, just briefly touching upon, what is pediatric palliative care and what is the key concept of total suffering. And when we talk about palliative care and what we do in providing palliative care, and then what are some key strategies that a palliative care provider, a neuro-oncologist caring for kids with brain tumor, a radiation oncologist caring with kids with brain tumor, radiologist, all can integrate into their practice to relieve their sufferings. So we'll start with the case. He was our very own boy, 5-year-old AB. He was a smart, brave, a strong little boy. He had DIPG diagnosed a few months back. When he came in, he had some difficulty in walking, intermittent headaches, and burning sensation in his feet. Parents was the very young couple, and of course there was a lot of anxiety in seeing their 5-year-old dealing with this DIPG, for which we cannot offer much of the treatment. So rightly so, the anxiety was there. And on examination, that kid had the drooping of his left side of the lip, ataxic gait and all. So he came in the hospital in the clinic to meet with the neuro-oncologist, and then palliative care team started seeing this family as well. So, so what is pediatric palliative care? I think we have seen this slide many times, and I'm also sharing this slide from one of my mentors. Is like palliative is the word palliative comes from a Latin word which means to cloak and to holistically cover and care for the family, and through your compassion. And when we talk about compassion, the word compassion comes from come and patty. Come in means together with, and suffer patty means to suffer, means to suffer with. And I think as a part of our job as a physician caring for these kids and family, our job is to take this suffering upon us as well in the form of a compassion, so that we can feel for them, and our actions will depict the way we want to care for them. So yeah, so we all know that palliative care, and I don't want all you to relate the concept of palliative care with end-of-life care here. It means helping kids to live well, and to live well, and which can be done by emphasizing on improving quality of life. And when we talk about improving quality of life, which can be done through prevention and relief of suffering, when we can identify them early and assess them and provide the treatment of pain and other problems like physical, psychosocial, and spiritual. And when we can do that, the relieving of suffering means caring for them holistically, improving quality of life, and relieving their total suffering. And it's a multidisciplinary team approach by a physician, nurse, social worker, spiritual advisor, child life therapist, and a psychologist. And we know that the outcome for the brain tumor are not very much, the outcomes are not very much optimistic everywhere. So while the patient, they do not survive, the family requires grief and bereavement support. And when they survive, the bereavement support for the surviving parents and their siblings. So this is what I was talking about, the concept of total suffering. So I think I always teach my medical students here and the resident here that as a neuro-oncologist or as an oncologist, our enemy for our patient is cancer. We want just to cancer to get treated, and we want our patient to get rid of the cancer or the brain tumor. As a PICU specialist, our enemy is death or maybe putting a patient on the ventilator. But as a palliative care provider or anyone who's providing palliative care in whatever capacity, our enemy is suffering. Not only our patients suffering, but their families suffering, their siblings suffering. And the suffering, this is the whole total concept of suffering. And the suffering is not just related to brain tumor, its prognosis, its comorbidities, but there are lots of physical factors that plays the role, along with that psychological component of depression, anxiety, fears, their control, their dignity, their conflicts, their guilt, their social factors about their culture, values, beliefs, their financial resources, their spiritual values, their activities of daily living. And then when the patient is towards the end of life, how best can you manage and provide support during that difficult time? And not only during that difficult time, but after that as well, in terms of bereavement support. But all these factors are centered, are patient and family centered, based on their demographics, their culture, their personal values, their beliefs, and their practices. So who are the predictable sources of suffering? AB, in our case, AB was with the DIPG, and he must have that feeling of having the physical symptoms of headache, anxiety, difficulty in walking, and maybe challenges in understanding what is happening with him. Why is he having these symptoms? And then the other source was family, his young parents. Why us? They must have some kind of psychosocial distress from seeing AB suffering from brain tumor, or having that existential distress of possibility related to the questions that comes from did we do anything wrong that God punished us in the form of this DIPG giving to AB? And then AB's sister, she has one younger sister, that what is going on in the family? She's thinking that the whole dynamics in the family has changed now. My parents are just caring for AB. No one is looking after. Everybody is asking me to just stay with grandparents so that they can bring AB to the hospital. And the care team, the neuro-oncology team, the radiation oncology team, us, the palliative care team, who are trying to help AB's family cope with the new diagnosis of DIPG, and its prognosis, and to help maintain hope for recovery or improving and providing better quality of life. So talking about AB and its DIPG, we know that brain tumors are the second most malignancies of children and adolescents. Approximately 500 if children are affected per year, and represent the most common cause of cancer-related death in children and adolescents. The tumors fall into both high and low grade category, and we know that the high grade tumors have poor survival. And their suffering comes from mainly the symptoms and side effects, not only from the tumor, but also the effects of chemotherapy, radiation, their surgery, their direct disease sequelae we talked about, which can be relieved and which can be ameliorated with the provision of palliative care here. So literature has talked about integration of palliative care with kids with brain tumors. And they have mentioned that this care is very critical to provide optimal care when we talk about the family as a whole. And providers who are caring for these families, they should be focusing on essential pain and essential symptom management, their communication skills that can help them in establishing goals of care plans, which are very family and patient-centered. And they focus on to ensure that the intervention, whatever the intervention they are hoping to provide, are only used when the potential benefits outweighs their risk, and to enhance the quality of life despite the disease trajectory of DIPG in the case of AB, and towards healthy bereavement for the family, so that their grief remains normal and physiological, and to prevent the grief become pathological here. So what are some key strategies that we can discuss here, and that some of them we provided in our AB's case to relieve suffering, AB's suffering and his parents and his family suffering. So I think we cannot agree more with this number one strategy of communication here. So communication is critical. I think we need to do it more often than we realize, right? Day in and day out. I think without communication, I think nothing is possible. But in case of palliative, we cannot just move forward. Our word matters. The words we say and we don't say, they matter, because up to 95 to 97% communication of ours is non-verbal communication. So and says that the communication is the procedure of a palliative care physician. And it was very well written in the book, where I think majority must have read this, When Breath Become Air, that when there is no place for the scalpel, words are the surgeon's only tool. So listening, truly listening to patients, to AB, to his young parents, and to all our colleagues who were caring for AB, is the key in providing high quality palliative care. And we'll talk about listening here as well. So when we think about communicating with these families, with the question that comes in our mind, and why do we need to communicate well when we provide palliative care? Because being a skilled communicator ourselves, it has a big impact on how family cope, and how AB coped, and how his parents cope. And then communicating well, it's rewarding when we do this very well. And it becomes stressful sometimes, and I think more often as well, when it didn't go well. And it happens to everyone. Then when we debrief after coming out from the room and after seeing the consult, and anything that did not go well, it becomes stressful to us, especially the communication. And then it's also satisfying on the other hand when it went well and it goes well, and then satisfaction on the other hand can minimize and does minimize our burnout to some extent. So why this is why and what is most important for the families in communication, and why was the communication was important for AB's family? Because they wanted to hear the facts which were clear and understandable, and the information was very much understandable for them. And this is all what the literature says about communication. Even because the parents think that even when if the information is hard for us, they still want to hear the truth from the care provider. They want the communication would be the honest and with empathy. It should respond to their concerns and their emotions, and discuss what can be done in suggesting realistic goals, and should include parents in decision making, because it should not be the paternalistic approach caring for them, taking everyone into account, especially parents, in providing high quality palliative care. So these are the three core skills that we use, and I think that whoever is providing palliative care is learning and using these core skills of effective communication. Means active listening. When we talk about active listening, it means letting AB's parent speak and talking about how do they feel about AB's condition, what is important for them, and then encouraging them to talk more, and listening keenly to the hidden questions, and with allowing the short periods of silence so that they can clarify, they process their thought in their mind. And then responding with emotions and responding with empathy. And I think we all know that empathy is a feeling that is an act of feeling that whatever the other person is feeling, that we can feel for that, for those emotions. But responding to empathy is when we convey the understanding back to them, that we really understand what you're thinking. And I think we all know there is a framework which is very standardized, used across the globe, NURSE, which help us to articulate and respond with empathy by naming the emotions, understanding where the family coming from, respecting what they want to do, what they're doing, and supporting them with their decisions, and then exploring what do they want to do more in providing care to AB. And then when we have these communication skills and effective communication to deal with these families, that will help us in establishing goals of care plans in collaboration with AB's parents and family. And because our goal is to provide goal-directed treatment, because sometimes without knowing the goal, we feel that, and the family also feels that we are doing just things and stuff to the patient and not for them. So what we did for AB, and what are the goals when we talk about the terminal illnesses like brain tumor and all. So these are the four main goals that we usually think about when we care for these kids, and then based on their goals, we align the goals together. So the first one, whenever the patient comes in, and whenever AB came in, although it was DIPG, but the cure was not there at that point. But whenever there is a goal of cure, there is the intensity of assessment and intervention to treat that brain tumor is very high. Our psychological approach to treat that tumor is to win that disease and to annihilate that tumor. But when AB came in, the cure was not in the question anymore. So the family really wanted to just explore options by leaving no stone unturned. They want just prolong. Can you prolong life for AB? So at that point of time, our neuro-oncologist or AB's parents, us as palliative care providers, radiation oncologists, maybe they have their intensity of assessment intervention was very high to moderate at that point. Our psychological approach was to fight with what ABs was suffering from, and just to provide that enough support so that they can see enough response, maybe near to cure, although it was a very, very long shot. So then when we explored all the options for AB, and they went outside Pakistan and wanted to explore options, and they figured out that across the globe, nobody can provide, and none of the trials are there yet, even to go near cure. So the parents asked to live as long and as well possible. Means, can you prolong his life comfortably? And at that point of time, when we were thinking about this goal, our intensity of assessment intervention was mild. Our psychological approach was like to live with it, that the patient can live with it. And then the effect of tumor is to just arrest the growth and maybe to slow it down so that his ataxia can become better, his facial palsy can become better, he can have the better quality of life, and he can have the best time with the family and the siblings. And when with the radiation, with the steroids that he was started on, and he remained well, but gradually the disease started deteriorating. Excuse me. And then parents asked for just make this as possible that he can just live as well as possible, just providing comfort care. At that point of time, our intensity of assessment intervention for AB was very minimal, and our psychological approach was to just embrace the situation at that point and helping them in providing good quality of life. And then the response to the tumor and disease was none. But here, there was a dual goal of comfort. Whichever goal the family was choosing, the goal of comfort was always there for them. And while we were thinking about the goals of comfort, we did talk about some of the factors that helped us in making the decision of goals of care plan, and then suggesting the treatment options for him. That what was suffering was for AB and for the parents. What quality of life did they want for him, like to spend quality of life with the parents? They may want to, they wanted him to go and enjoy time outside the city as well. And then despite knowing the prognosis and all, anything that's very special for him, he has loved cars, and he has a lot of cars. He had a lot of cars with him as dinkies and everyone and everything. And then what are the hopes and values for the families, and how do they think what's the definition of good parent for them, that whatever they are providing is in the best interest of AB. That's how we decided their goals and the treatment option and plan, which were not very much, but in terms of radiation, steroids, and symptom management. Because sometimes and too often we do the way because we can, not necessarily contemplating if we should be doing. So taking into account all the factors, coming up with the goals of care plan that aligns well with the family goals of care plan can help you decide the best option and make the best decision for the family and the child. So third strategy is to understand the importance of hope as a care provider, because sometimes these are our own fears that communicating bad news will take away hope. But this is not right. Communicating challenging news does not take away hope. However, in sharing information, prognostic informations, help family cope with uncertainty. And that's happened with AB. And while we were honest and clear in providing them the information that the DIPG is very progressive and very fastly deteriorating. So they did get a sense of realistic hope that, we do not have much time. Whatever time we have, we want to spend it with the family, despite him deteriorating in terms of seizures or difficulty in swallowing and other things. So the importance of hope is still there. And with all this dual goal of comfort and every goal of care for terminal illness, there is always an hope, and there will always be a hope attached with it. And then measuring pain and other symptoms, and the level of distress by addressing the symptoms of greatest concern, because as the burden of the disease increases, the symptoms also increases, and which did happen in the case with AB here with DIPG. So when we talk about the symptoms and their management in brain tumor, so the symptoms are basically secondary to the location of the tumor. Supratentorial tumors are associated with seizures, coma, nausea, and vomiting. Infratentorial tumors are associated with ataxia, and the brain stem tumors are associated with speech disturbances, cranial nerve palsies, swallowing dysfunction in tetraprasis. So AB had DIPG, so he had initially speech disturbances, he had a cerebral palsy as well. Later on, he did develop intermittent swallowing dysfunction with the general symptoms of fatigue, body aches, pain, dyspnea, dysphagia, dysarthria, hearing and vision loss, paralysis, seizures, agitation, headaches. And headaches in kids can be presented in the form of agitations and behavioral changes that we noticed in AB. So 36% of patients with brain tumor present with headache. And I think the first line of drug is to use acetaminophen, and followed by opioids and dexamethasone to have its anti-inflammatory effect. Neuropathic pain medicines can be beneficial, but sometimes it can take a week, days or a week to become more effective. But when we use steroids for headache, we start with the lowest possible effective dose. And then sometimes we can start, and we do often start with the high dose to have the anti-inflammatory effect. And as the symptom goes down, we can come to the lowest possible effective dose and then wean after the control of the symptoms. And NSAIDs are typically avoided because of the risk of bleeding at the tumor site and the risk of gastric ulcers with the concurrent use of steroids. But again, it always depends on the trajectory of the disease, that at what point of the trajectory of the illness we are using NSAIDs and steroids, and what are the goals of care plans at that point of time. Seizures, 30 to 50% of patients with brain tumors can present and have seizures. And seizures cause distress to the family, patient, and may also cause worsening cognitive and behavioral functioning. Our goal to control symptom is to control seizures and to optimize period of alertness. That's why we want to control seizures. And there isn't any evidence to support the use of prophylactic anti-epileptic for seizures. And because maybe the use of prophylactic anti-seizure medicine can cause sedation or agitation, and which the family doesn't want. They want those periods of alertness so that they can interact and they can see their child interacting or even seeing them. And then, so for acute seizure management, benzodiazepine are the drugs of choice. We all know that. Diazepam, lorazepam. We do not have lorazepam. Maybe other countries have and other countries do not have. But they both can be given rectally. Lorazepam and midazolam are both absorbed well intranasally as well. In terms of chronic seizures, and levetiracetam has a promising role with the fewer side effects and tolerance. It can give a brief period of aggression and aggressiveness, which can vary from patient to patient. But we should supplement it with vitamin B6. AB did have intermittent seizures. He was on multiple anti-epileptics, but he gradually, and then not gradually, but during the end of life period, he started having refractory seizures, and then he developed status epilepticus. And so in case of status or refractory seizures, having neurology on board to inquire about other anti-epileptics, and us as palliative care team for midazolam infusions, keeping in mind what are the goals of care, again, plans with the family and all. Because neurological tumors are associated with dysphagia, so they have difficulty in swallowing. So I think rectally administering anti-epileptic medications, they act more quickly than other oral anti-epileptics. So the third symptom that these patients have, and our patient did have as well, as nausea and vomiting that can be related to treatment or the direct effect of the tumor, because the vomiting center receives input from two nervous systems controlling areas. We all know the chemoreceptor trigger zone, and the peripheral input source of vagus nerve, which use a multitude of neurotransmitters like histamine, acetylcholine, dopamine, serotonin, neurokinin, and we use all entire form of these receptors to control this nausea and vomiting. But when we think of controlling nausea and vomiting, our goal is to make patients interact with the family. And not only our goal, I think the family goal is to make patient interact with them. so that they can take by mouth foods they enjoy and maintain nutrition and hydration as much as possible. In case of intracranial pressure causing nausea and vomiting, I think steroids are the first line of drug and treatment. We need to find out the cause of nausea and vomiting in these patients. If that is chemotherapy or radiation induced, prophylaxis are recommended before chemo and radiations. They can be given as a scheduled medication and as PRN as well. As far as the non-medical therapies are concerned, which includes hypnosis, acupuncture, and I think we are also trying, and I learned from St. Jude as well, the use of aromatherapy here. And I think a couple of kids have, not the brain tumor kids, but other cancer kids have liked lavender oil and as a form of the aromatherapy, and which has done wonder for them. And then other practical remedies like treating constipation as an underlying cause, removing noxious smells, rotating opioids if they're causing nausea, providing emotional support, and maybe, and I think that's important, guiding the families to modify meals to be smaller and more frequent so that they cannot have a bulk of meal, and which gives them the fullness and the dumping kind of a syndrome, and then cause them nausea and vomiting here. And then comes pain. Pain is an important component of suffering because it interacts with other component of distress and contributes to overall suffering in our patients. And in this picture, as we can see, that the pain is not just the organic pain or the nociception, but it also has the emotional component, the psychosocial component, the spiritual component, the emotion, and the cognitive influences. So how important and how much important is to relieve pain in these patients? So as far as, I'm not talking about pain in detail over here because it's very difficult to talk about everything in treating patients with brain tumor. But as far as the AB was concerned, or these patients are concerned, we can relieve that pain through our palliative radiation options. So we did it for AB here as well. There are surgical approaches as well to relieve that pain, or consulting like we did with radiation oncology, neurosurgery, to come up with the plan, or maybe put in a shunt on anything involving pain specialists, pain or hospice and palliative care specialists, to help them in providing multimodal analgesia, which helps improving quality of life these patients. And then in terms of uncontrollable pain, palliative sedation to the level of unconsciousness, which necessitates consultation not only with a palliative care specialist, but also a ethicist as well. So what's the sixth strategy besides managing symptom and all? Because we knew that the AB was going towards and approaching towards the end of life period. We started talking about legacy development, legacy making, and the memory making thing with the mother. It was very difficult to talk about these things with the mother because, of course, she was not ready to lose her 5-year-old, but we did manage to talk about some of the last wishes. These are some resources which are there as far as the young kids are concerned, or adolescents are concerned. There is an international and global foundation that cares for kids as far as the making wish possible. And then we can come up with a memory making box. We do not have a memory making box in the form of box, but we do tell them about what we can do in terms of memory making. So we did provide an option of making a memory of AB in the form of having his fingerprint engraved in a form of a pendant given to mother, or one of his handwriting that can be captured or that can be made in a pendant so that mom or dad can use in the form of a keyring. We did offer parents his favorite drawing to be kept as a pendant or a keyring for dad, or his ECG that can be kept as a pendant for them. So the mom chose his fingerprints. And what we did spend time when mother was very deficitated and AB came in with refractory seizures. We made this as a therapeutic activity for him while he was asleep with the midazolam infusion. And mother spent the whole day collecting 20 fingerprints and we managed to make one for him and for the mother. And then end of life decision making, which is the most important component, because preparing the family for the possibility of incurable illness, its progression and death is very, very important. And the best you can do is while providing your effective anticipatory guidance, then what is coming next. And I am telling you, and that's my promise, that every single parent who are going through this difficult time and who have seen these difficult journey of their child, they really want to have this anticipatory guidance. Please do not refrain yourself from giving them anticipatory guidance, but do not forget to use all 3 core skills of effective communication, because that matters a lot. You cannot just go and read the textbook or the bullet points in front of them. Maybe you have to discuss one single point in every single meeting, or maybe 1 point in 2 meetings in 2 days. But this, we have seen that, and I think this has helped family a lot in processing and thinking about how important is to care for the kids who will not be there with them after a few days, because this effective anticipatory guidance help family prevent having decisional regret prior to death of their child. And that's what we did with AB. And not only for the AB, but also for his sister, guidance on sibling support. How can you involve his sister during his care so that she will feel not in his care, but also a part of the family, so that she will be there with you in the hospital rather than spending time with grandparents, because we feel that the siblings will be heard or will be scared. And because when the parents do have these decisional regrets, they have high level of anxiety and depression after the death of child. They miss more days of work. The quality of life become worse and worse, which can result in high mortality rates as well. And then after the death, the support for these parents and family in terms of grief and bereavement, recognizing its importance is our public health necessity. Know what you can do to be supportive. Maybe just picking up a call, making a phone and making a condolence call, or sending a condolence card. Read some of the books, sit down together with them, read some of the books, share some brochures if there are any. If we can celebrate, then maybe a day of remembrance for them, or coming up with a bereavement resource package. And I think culture related, and maybe help them make some of the resources for the other parents as well, because we as care providers are a critical component of our family's grief and bereavement journey. So we are here to support them, and they are counting on us. So they need our support. And these are the bereaved parents who have said that how have they felt about the care they received, and what they think about the receiving care in terms of bereavement. They said the importance of strong and ongoing relationships between healthcare provider, bereaved family has helped them. The importance of high quality communication was one of the most prevailing concept in providing bereavement support. The effect of negative experiences between healthcare provider and families on parental grief was there. And they talked about the importance of the role of institution who's caring for these family in the journey, what the bereaved parents have felt. Then what happened, I did talk about AB throughout the presentation. So this was the concise and precise summary of what we did as a palliative care team for him. So I talked about him as a smart boy of very strong and loving parents with the DIPG. He was a fan of cars and dinkies. He was a favorite student of his class. He was a pre-K, and in pre-K, he was loved by everyone who ever came in contact with him, with a beautiful smile I can always cherish in my memories. He was very close to his mom and had loved her so much that he hid some of the symptoms not to worry her. And that's what his mom has told me after his death, with one little cute sister who was there with the family. What palliative care did was the care coordination component with the other team and the primary team in helping them in making a plan which aligns well with their goals. And then, like I talked about, the goals of care discussion, the family started with leaving no stone turned, like exploring options outside Pakistan. They did go to Chicago and explored option as well. And then when nothing was there and they knew that there is nothing much provided, then the goal was just to live as well as possible with radiation and steroid, and then eventually just symptom management as comfort care. We did manage his pain, anxiety, depression, nausea, vomiting, intermittent seizures, and then he developed status, and then he was on midazolam infusion for good 4 days, and then he passed away in peace. We did help family in providing psychological, emotional support in the form of regular follow-ups throughout the course of illness. And then end of life care for him was like midazolam infusion causing him to be sedated to the level of unconsciousness, continuous, constant anticipatory guidance on what's coming next, supporting the sibling and the family, memory making, and then finding a right place where the family wants him to die. And they chose hospital room where 50 family members were there every day during the last 4 days. And they had a quality of life time together during the end of life period of AB's death. And then a bereavement call and a check-in message whenever I find time, just to say hi that and to the parents that just checking in about and thinking of you. And this was mom's message after a week he passed away. She said, "Assalamu alaikum," which is the greeting in Islam, like "Assalamu alaikum, Dr. Resham. It's AB mom here. I love you and I love you, Dr. Noreen," who was his neuro-oncologist. She said, "You are all wonderful people with golden heart made with iron." And she was the mom who was really very devastated during that time. And she just sent this message after a week of his death. So these are my references. And I'm so grateful to all my mentors who have taught us and who has given me a couple of slides and all. And thank you to the group for choosing this topic in the very important month of September, which is our Cancer Awareness Week. And how can we better support? And I'll end my talk on this sentence that I always teach medical students, say that a good outcome doesn't need to be alive every time. If you can help them throughout their journey in relieving their suffering, and even there is an end of life period time, you can if you can help them die with dignity without pain, this is the best outcome. So thank you so much, and I'm happy to answer all the questions and comments. And Mirai, I'm going to unshare my screen now. Okay.
Yeah. Okay. Thank you very much, Dr. Resham. It was an excellent talk. Thank you very much. You touched upon very important points. It was so clear, and it's going to be very useful for all of us, I think. Dr. Kebudi, would you like to contribute to the discussion session, please?
Yeah, Mirai, thank you. Thank you, and thank you, Michael, also. Resham, thank you a lot for this very really comprehensive talk, and you have taken us all through the journey with that little patient of yours, and you have selected a very important patient because DIPG is most of the times fatal. So it is one of the illnesses, one of the brain tumors, one of the cancers that really needs so much importance during palliative care. Thank you so much. I have written whether anyone has any questions in the chat, but maybe we can emphasize, you have really emphasized the very important points. We can just summarize, like, communication is critical. First of all, communication with the family, with the child is critical, and with the healthcare team. Resham, in this respect, I will ask you one question. Well, especially in the low middle income countries, we do explain everything in detail, all the prognosis, everything to the parents and the families. However, sometimes many parents in our cultures, and because we have to respect the cultural differences also, they would like to avoid some of these prognosis from the children. What is your view in this respect? One of the questions would be that, yeah.
Thank you so much. I think, Rajan, this is a very important question. And I think every day we do see these families who want to avoid prognosis, and not just the prognosis, talking about the primary disease in front of the patient and their child. And so I think, although we say that this is cultural and all, but sometimes I also think that who makes this culture? We, right? We are the people who make this culture, right? Maybe we are the one, we will be the one, and we can be the one who can start making little changes, right? Like we do talk to parents about, with respecting, with all their respect, that so it's good to talk about child in an age appropriate manner, that what's happening with them, because you cannot have a child with just enteric fever or typhoid fever in the hospital for a month. You cannot have a child with just abdominal pain in the hospital for a month and getting these bone marrows and ITs and sedations as well. So we always tell them that we are trained in providing age-appropriate communication. Let's give us the opportunity, or let's start together the conversation. And the only way we can start conversation is like exploring what they want to ask and helping them, encouraging them in asking them questions. And because sometimes kids give us the lead that they want to ask few things or things from us. So, but as adult, we think of very intense and dismal prognosis, and we can reach to the level of death as well. But the kids cannot. They just process.
Sorry, I can ask you more specifically. As you say, we have to talk age appropriately.
Right.
Usually, do you talk about death, or do parents want to talk about death? You know why I'm asking this? We have had 3 very important studies published. And one of our head nurses, she's in pediatric for 30 years, she was the one that interviewed the mothers whose child had died of cancer. And what the 3 questions were whether, because most of them would not prefer to talk about death, if they were disappointed, whether when they think back, they would have better talked about death with them, because they try to avoid that the death, the word death, and also that they are dying, and whether they wanted to die with another. That it was whether they wanted to die while in the hospital or at home. So these are quite specific. I mean, these are important things in high income, because emotions are everywhere in high income or low middle income countries. But we know that we have to respect the cultures and the families, because otherwise we cannot have a journey together, because they can just go away and not listen to you. So we have to sometimes respect the cultures, especially about do the parents in your setting or in your experience talk about death with their children, or want to talk, or they avoid it?
So I think the right answer and the straight answer is they do not want to talk about that. They have their fears, they are scared. But I would say, on the contrary, I have come across a couple of patients who were teenagers who had talked about death themselves in front of parents. He said one of the osteosarcoma kid, he was on a life-prolonging medications, no was there, the disease was already metastatic. He said, I don't want to die in front of his mother. He said, give me something to survive more. Just give me. I don't want to die so early, and I don't want to die right now. So I think he was the bravest, one of the bravest kid that I saw in my this 1.5 year experience. That he was like, and the mother was like just broken down and all. But I think after that, the time becomes so easy, and the end of life time was so easy for them. Although he was in a distress, but he had lived his life on his own terms. He wanted that chemo, he wanted to live, and he talked about that very clearly. But parents, they do not.
Thank you.
Thank you very much.
If we're and the second was to establish the goals of care in collaboration with the patient and the family, which is very important. Just so that we summarize your very nice talk. Understand the importance of hope. Hope is very important. You have really emphasized that. Without hope, because sometimes they will say, well, I mean, it's terminal, but even the hope of one day, a 1 month is so important. That's very important. So we shall respect that hope of the families. You have told about that so nicely. To measure pain and other symptoms and level of distress, address symptom grades concern, very important. That is.
There's a question from
Volkan, I think.
Yeah.
Mirai, would you like to tell about that? And then I can continue.
Yeah, a question from Dr. Hazar. Thanks for this excellent talk. My question is about the people at the other side of the line, meaning I think healthcare providers. What are your suggestions for doctors to avoid burnout syndrome? I think there will be a session in the annual meeting.
Yeah, there is a session.
Yeah.
So I'm not going to be the spoiler here for the session, but I think this is one of the most important topic. An important point to consider and about the burnout. I think the simple answer is, as a care provider, we do need to take out time for ourselves and find out our own self-care mechanism, whether they are physical mechanism. I do go for my Pilates activities twice a week, so that I can help that can help them release endorphins and give them to me some kind of a pleasure, so that I can feel and I can feel to come back again the other day and do the same work. You need to have some kind of a spiritual care mechanism, maybe do yoga or meditation, some kind of thing. Taking a break and going for travel or something, just distraction. But you need to practice and find out time for this thing. This is important. And I have learned this over a period of 1.5 years, that whenever I think I'm becoming overwhelmed with all the patients and the care, I do go into that burnout thing, and I can recognize that feeling when I'm thinking I'm not giving enough time to me. But we can continue this thing in our annual meeting, that what we have to learn more about in providing and getting self-care for all of us.
Thank you, Resham. Especially in this mindfulness intervention are especially really recommended for both the healthcare professionals and the patients. And in fact, we'll be talking about integrative oncology in the meeting also in Honolulu for the ones that are there in the educational day, which is palliative care has also, I mean, as you have said, the palliative care has to be integrated from the diagnosis to the end of life. And so to facilitate legacy development, end of life decision making is very important, especially where they want to die, for example, at home, and how can we help the people. Grief and bereavement support is very important. And something that you have told, like you said, this little boy, the 5-year-old boy, loved the mother so much that he hid some of the symptoms not to worry her. And this is really, we see that many times, especially in adolescence. They know everything. They know they'll die, but because the parents will feel sorry about that, they try to avoid the word death, or that they know about their disease. So it's like a theater between the parents, and they are playing a role and trying to avoid the sadness or the sorrow of each side. So I think you have really emphasized these points so much. So nice. And also, thanks to Noreen, who is doing your neuro-oncology, and to Resham. The multidisciplinary team is very important here. The physicians, the nurses, the healthcare professions, and in the multidisciplinary, we are talking about the brain tumors, so it's the neuro-oncologist, the surgeon, and the radiation oncologist all together. So I really would like to thank you for this excellent talk, and also the participants.
Yeah, thank you very much. Thank you very much. I want to also emphasize that, Dr. Kebodi, Dr. Resham has started approach, which is called, I think, if it's wrong, bereavement tray, right?
Yeah.
Can you do you want to talk a little for approach you have studied at your institution, Aga Khan University?
So I think
please.
It was about, it's kind of bereavement tray is a food tray for parents of those kids who have like hours or last few days left, and who are towards the end of life, and they have chosen hospital as a place to die. And so this is a regular food that comes from the food department or the diet, our cafeteria for the parents, so that they don't have to leave the bedside to go to the cafeteria and get the food. Whether they eat it, because it's very difficult as a part of our culture. It's very difficult for them to eat when they see their child dying in front of them. But it's a basic necessity as well, right? It's a basic requirement. So that's why we started this initiative.
Yes. So yes. So the patients and their caregivers understand that although there's no cure sometimes, but they feel the support from the institution, from the healthcare team. It just it doesn't stop at the end of life, and it goes on beyond the agreement. Yeah.
And one thing, Mirai, in the group, that this trade doesn't not only help the parents to feel that they are supported by the institution, but also it supports the nurses who are providing care to these kids and other care providers, right?
More
from the
connection
to the hospital porter or the help, that they are supporting this family in some way or other, so that they will not have that some moral distress that we did not do anything to save this child. So yeah.
That's a way to make them understand how they feel about them. Yes.
Yeah.
Thank you very much. This was an excellent talk. Thank you very much.
Thank you so much. Thank you so much.
Thank you, Resham. And thank you, Mirai, for inviting me as a discussant. I think the time is up, so you will be...
Thank you very much, Dr.
We'll be closing up. Yeah.
Thank you very much for everyone coming here and being here. Thank you very much. See you at next webinar and maybe in Honolulu. Bye-bye.
Bye. Bye. Bye.